Thanks again, Mike and Davo, for the invite. It's a real pleasure to be here. So in the next half an hour or so, I will tell you about a little bit about an overview, really, of our work on endurance exercise. And in doing so, I'll try to debunk a widely held myth in exercise physiology. So let me start then by answering a question we often see when we write grants. And the question is, why spend time, money, and inspiration studying endurance exercise when there's heart disease to consider? And the answer is this: well, public participation in endurance events is on the rise, and more than ever, you have people participating in ultra-endurance events like long-distance marathons and triathlons. And here's a serviceable statistic. Last year, there were over 500 marathon race starts in Europe and America, with over 5 million participants. And this number was projected to increase by 5% every year. And these figures really provide the impetus for clinicians, policymakers, and scientists to really understand the effects of high-intensity endurance exercise on the heart. More so, as a large body of evidence now shows that there comes a point where the improvement in the well-recognized benefits of moderate endurance exercise start to plateau or even decrease, or the risk of cardiovascular events starts to increase at high intensity exercise, and this is due to an increased risk of cardiac arrhythmias. Now, these are primarily supraventricular, and they include brady-arrhythmias, or a slow heart rate, atrioventricular block, or dysfunctional conduction through the AV node. Now note that brady-arrhythmias and atrioventricular block can necessitate pacemaker implantation, and this is known to be more frequent in endurance athletes with a long training history. And there's also the incidence of atrial fibrillation in athletes. Now this is a supraventricular arrhythmia that requires little introduction. It's a major public health burden and contributes disproportionately to increased morbidity and mortality. Now these mechanisms are very poorly researched or poorly understood, and are currently entirely attributed to increased vagal tone or heightened vagal tone that accompanies training. Now by this I mean an increased tonic discharge in the parasympathetic vagus nerve that innervates the heart. And what I'm going to try to do in this Zoominar is convince you that all these arrhythmias are not due to high vagal tone, but due to intrinsic electrical remodeling brought about by exercise. Now, if I'm going to debunk high vagal tone, first, let me just consider the basis of this theory. And I have to admit, on first glance, it's a good one. Let's look at the effects of vagal stimulation on the sinus and the AV node. Now, parasympathetic stimulation impacts cardiac electrophysiology, as we all know, on a beat-to-beat basis. And in the sinus and the AV node, it reduces the frequency of action potentials, and this lowers the heart rate and impedes or slows AV node conduction. Now, this is due to activation of IKACH, which is an acetylcholine sensitive potassium current, and also due to suppression of two key ionic currents important for pacemaking and impulse conduction through the AV node. And these are IF, which is a hyperpolarization activated current, or the funny current, and also the L-type calcium current. Now, can I draw your attention to the ion channels that carry these currents, as I will refer to them extensively during this talk. So the funny current is carried by HCM4, and the L-type calcium current is carried by Cb1.2 and 1.3. So what about the atria? Now, vagal stimulation and activation of IKACH in the atria hyperpolarizes the membrane. It shortens the action potential duration, increases the effective refractory period, and also increases, and because innervation of the atria is heterogeneous, vagal stimulation also increases the spatial heterogeneity of the effective refractory period. Now, regional dispersion of this has been shown to be pro-arrhythmic, at least in dogs. So given this physiological relevance, it may seem intuitive almost that high vagal tone is considered a central tenet of, or the basis of training-induced arrhythmias. However, if you look at the mechanisms, here is where it starts to get a bit more murky. Now, one thing to say is that vagal efferent activity has never been directly measured, cardiac vagal efferent activity. And most of the basis of high vagal tone is based on surrogate measures of vagal tone. Now, one of these is heart rate variability, which, as we know, is a beat-to-beat variation in the heart rate. Now, previous work by our group, pioneered by Mark Boyer, has shown that in many cases, or in all cases really that we've looked at, there is an exponential decay-like relationship between heart rate variability and heart rate. So the increase in the high frequency component, which is a surrogate measure of vagal tone, is likely due to a concurrent decrease in heart rate. Now, in the interest of time and the general narrative of this talk, I won't get into these mechanisms, but I refer the interested listener to several counterpoint style articles we have recently written on the topic. Now, another line of evidence or another surrogate measure is given as the effect of vagal block on heart rates. Now, this is a bit clunky, so bear with me. So the theory goes that if the vagus nerve slows down the heart rate, then full vagal block should result in greater heart rate acceleration in trained subjects with high vagal tone. And on the basis of some animal studies, this is given as evidence for high vagal tone in athletes. Okay, so to provide consensus, as there are other instances where this is not the case, in recent work we collated studies that included systemic muscarinic block of the vagus nerve in human athletic cohorts using atropine at 0.04 milligrams per kilogram, which is considered to be a full blocking dose. Now, as per the theory, full vagal block in this way should result in greater heart rate acceleration in trained subjects with high vagal tone. But as you can see, in trained subjects in pretty much every single human study considered, this is not the case, and the heart rate is still significantly lower even after complete parasympathetic block. So now I hope you will allow that if in the absence of direct measurements of vagal tone, and if surrogate measures do not necessarily stand up to scrutiny, the theory of high vagal tone as a major driver of training-induced arrhythmias must be challenged and alternative mechanisms considered. So this is what we did in previous work. And in doing so, we looked at the most common training-induced rhythm disturbance. Let's just humor me and call it a disturbance for the sake of argument. And that's training-induced sinus bradycardia, or low resting heart rate. Now, to put things in context, if we were to take our pulse, I think the average would be about 70 beats per minute. But in elite athletes, this can be as low as 30 beats per minute. So what underlies this effect? So previously we examined the high vagal tone theory in human athletes and rodent models of training. So we found that, as expected, the heart rate of trained athletes was lower, but this lower heart rate persisted after complete pharmacological block of the autonomic nervous system, and this is in human, in runners. Similarly, in mice trained by swimming, we found that the heart rate was lower not only at baseline, also after complete autonomic block, but also in the isolated and therefore denervated sinus node. So this really shows us that endurance exercise induces an intrinsic sinus bradycardia. So we then, in collaboration with Dario Di Francesco's group in Milan, showed that there was intrinsic electrophysiological remodeling of the trained sinus node, and notably there was a reduction in the current density of key ionic current, IF, and the predominance of IF remodeling in underlying training-induced bradycardia was tested by blocking IF, once again in human cohorts and in rodent models. So IF was blocked using avabrogene, which dose-dependently blocks heart rate in humans and athletic and rodent and animal models. So in the anesthetized mouse, under complete autonomic block, once again, we saw an intrinsic bradycardia, so the heart rate was lower at baseline, but application of ivabradine completely normalized this heart rate difference between trained and control animals. So let's now look at the effect of ivabradine in human athletes. What we observed that in humans, after complete pharmacological block, so trained humans are given as the red circles, not only did they present with a lower intrinsic heart rate, but also a lower responsiveness to the rate-lowering effects of ivabradine. And this again is suggestive of HCN remodeling in human athletes. We then showed that this change in IF current density was due to a reduction of HCN4 protein levels, and also that was then attributed to a reduction in HCN4 messenger RNA. So something we're particularly keen in pursuing in our lab is to understand the transcriptional control of pacemaking ion channels. Now, as you know, there are a number of modes of transcriptional regulation, but in our recent work, we have focused on microRNAs that are negative regulators of gene expression that perhaps require little introduction, but an oversimplification perhaps is that a microRNA can bind to regions of messenger RNAs. Frequently, these are in the 3' untranslated region, and this causes translational attenuation or mRNA degradation and blocks protein synthesis, and therefore it's an effective way of gene silencing. And we like microRNAs because they show tissue and chamber-specific expression in the heart. They've been shown to target ion channels. They're druggable compared to ubiquitous transcription factors, making them attractive therapies, few of which are in phase 2 clinical trials. So we're interested in them as a new class of antiarrhythmics. So in previous work, we identified a role for microRNA, for the microRNA 4235P, and we observed direct interactions between this microRNA and the HCN4 3' untranslated region. So to test whether this microRNA could impact training-induced bradycardia, what we did is we decided to inhibit it in vivo. So mice were trained for 28 days, which in our experience was sufficient stimulus for training-induced sinus bradycardia. And at the end of the training period, mice received an oligo that specifically blocks microRNA 4235P. And really what we were staggered to find was that blocking this microRNA completely reversed the heart rate difference between trained and control animals, not only in the intact animal, but also in the isolated denervated sinus node. And note that this looks a lot like the ivabradine effect. And we found then, by further investigation, that this reversal of training-induced bradycardia was due to reversal of the IF current density remodeling produced during endurance exercise. Now, this is the first demonstration of microRNA control of pacemaker electrophysiology and heart rate. So I hope I've at least managed to plant a seed that training-induced bradycardia is not due to high vagal tone, but instead due to microRNA-based remodeling of key pacemaking ion channels. Now, from another body of work, which I haven't covered in this talk, we then found that the transcription factor NKX2.5 is upregulated in training. And these transcription factor microRNA interactions explain transcriptional remodeling of the sinus node. And this is sufficient stimulus to sinus bradycardia without the need to invoke high vagal tone. So let's now move on to the next training-induced arrhythmia. And this is atrioventricular block in athletes. Now, very much like sinus bradycardia, AV block is frequently observed in trained athletes. On the ECG, first-degree AV block is given as a PR interval exceeding 200 milliseconds, but it can also manifest as second-degree type 1 AV block, where you have a progressive lengthening of the PR interval followed by a non-conductive P wave. Now, this was once considered a benign physiological adaptation to training. However, studies have shown that AV block in the long term can portend to adverse consequences, including a 2-fold risk for AF and a 3-fold risk for pacemaker implantation. Now, note that risk for AF and pacemaker implantation is well documented in veteran athletes with a long-term training history. And so understanding these mechanisms could be important in therapeutic options or future therapeutic options for this arrhythmia, for these arrhythmias in athletes. So this work that I'm about to describe is under revision for circulation research and delayed obviously due to lockdown. So if any of the powers that be are listening, please consider this the promotional tool. So something we often get criticized for in our work is that it is in rodents which have dominant sympathetic tone. So to target this criticism head on, we teamed up with Thomas Jespersen and Reike Bill in Copenhagen at the equine research facilities, and we persuaded them to show us some of their ECG recordings in racehorses. Now what we found that racehorses are a great model to study AV node dysfunction. There's several incidences of type 1 second degree AV block, so you have these non-conductive P waves, and also the Wenckebach phenomenon, where you have a progressive lengthening of the PR interval followed by a non-conductive P wave. So the data is summarized here. So in trained racehorses versus control, you have a significant prolongation of the PR interval and really a very high incidence of second degree AV block. So it's a good model to study training-induced electrical remodeling of the AV node. Remember, this is an animal with high vagal tone. And then we persuaded a PhD student in Copenhagen, Sarah Nissen. I also noticed that she's got a horse in the background. I cannot confirm or deny that he was part of the study. So what we got Sarah to do is to record the PR interval in the telemetrized horse, not only at baseline, but after complete pharmacological block of the autonomic nervous system. Once again, we saw a significant PR prolongation. Now this is first degree AV block at baseline, but also on complete block. And this once again shows us that the AV node dysfunction or slowing of conduction through the AV node is intrinsic to the heart. So we then decided to look at candidate mechanisms, and we studied some ion channels initially. Now the horse AV node, unsurprisingly I suppose, has not been characterized, and Helena Dobrinsky helped us identify elements of the AV conduction axis in horses. And by immunohistochemical labeling, what we noticed was, what we observed was a significant reduction in HCN4 in the horse AV node, and also a significant reduction in the L-type calcium channel subunit CLE1.2. Just a reminder that both these channels are important in AV node excitability and conduction. So, okay, so here you have first demonstration of training-induced electrical remodeling in a large animal model. But once again, to explore this mechanism in further detail, we return to our model of swimming, which is kind of like the old faithful. So in this experiment, mice were swim trained for 5 months, which in the literature is given to approximate 10 years of intense endurance exercise in humans. And just like in horses, we found that the PR interval was prolonged at baseline, but also on the complete block of the autonomic nervous system. So once again, the AV node dysfunction is intrinsic to the heart. Now, by pacing the heart in vivo, we also observe an increased a prolonged Wenckebach cycle length and a prolonged AV node effective refractory period. And both these parameters mean that conduction through the AV node is slowing with long-term high-intensity exercise. So we also looked at the isolated denervated AV node. So this is without any autonomic input. And what we observed was that the AH interval, or the time taken from the electrical impulse to travel through the atrioventricular node, so the AH interval was significantly prolonged in trained animals versus control. So we then decided to explore transcriptional remodeling mechanisms that could underlie this intrinsic slowing of AV node conduction. Now this, we believe, is a first in the literature to study the mouse AV node at this detail. So the mouse AV node presents significant challenges in accurate sampling because of its three-dimensional nail structure and its interdigitation between the atria and the ventricular septum. So we immunolabeled long-axis sections of the AV node with HCN4 to identify components of the AV conduction axis, and then sample them accurately using laser capture microdissection. So in this And then what we did is we looked at a targeted we did a targeted transcriptomic study to identify ion channels that could be dysregulated by training. So this was work conducted in collaboration with Shu Nakao, who is now an associate professor in Japan, very proud of him. So what Shu found is that with training, we see, so the data is given here is the train value normalized to the control value. So therefore, anything corresponding to 100 represents no change. And what we were surprised to find was a sweeping down regulation of many major ion channel families involved in AV node impulse generation and conduction. Okay, at the protein level, this translated into a significant reduction in the protein levels of the L-type calcium channel subunit CAV1.2 and also HCN4. Now, in collaboration with Matteo Mangoni's group and Pietro Masirca, what we then found was that these changes resulted in a significantly reduced current density of the L-type calcium channel current and the funny current in myocytes isolated from trained AV nodes from trained mice relative to control. And now when these changes were incorporated into biophysically detailed one-dimensional model of the AV node, these current density changes were sufficient to explain conduction slowing in silico. So something we're interested in now is to understand, just like sinus bradycardia, what causes this system of ion channel dysregulation. Once again, we focus on microRNAs. And this time we profiled about 800 different microRNAs in the AV node. We found changes in about 40 different microRNAs as given by the red circles. Now notice that a large proportion of these, well, all but 3 are upregulated. And this perhaps explains the downregulation of ion channel transcripts within the AV node. Now we then did a medium throughput luciferase screen. So basically what we do in this experiment is study whether any of these dysregulated microRNAs can specifically target the 3' untranslated region of 2 genes of interest. These are CAV1.2 and HCN4. Now, on the basis of these data and coupled with in silico predictions and further screening in SHOX2 cells that express these 2 ion channels, we narrowed down our microRNAs of interest to 2. These are 452 and 211. And what we're currently doing is studying the effect of manipulating these microRNAs on AV node electrophysiology. So what we're finding is that microRNAs are new regulators of conduction through the atrioventricular node, but this is a work in progress. So from this part of the talk, I hope I've convinced you in some way that using large and small models of animal models of training, we see that training-induced AV block is not due to high vagal tone, but instead due to electrical remodeling of key ion channels within AV node myocytes, that these are likely impacted upon by microRNAs. Now, this is a study with several firsts. We believe that this is the first demonstration of training-induced arrhythmia in a large animal model, and also very likely the first demonstration of microRNA control of AV node excitability and conduction. So we've only just started working on it, but I think it deserves a mention. We're now going to talk about the third supraventricular arrhythmia, which is atrial fibrillation. And it requires special mention because it is really the best evidence example of a training-induced arrhythmia, commonly diagnosed in middle-aged men with a long-term training history. Now, marathon runners, cross-country skiers, and cyclists seem to be especially prone. And the evidence supports a U-shaped relationship between intensity of high intensity endurance exercise and duration, and with risk of incident AF. Now, the mechanisms, once again, are not completely understood, and in contemporary reviews are given as vagal AF. And by the admission of some of the authors, this is a condition without universal definition, etiology, or diagnostic criteria, where characteristics like sinus bradycardia, sinus pauses, and AV block are given as determinants of vagal AF. And as we've seen, these can all be explained by intrinsic electrical remodeling that occurs with training. So this slide then summarizes current mechanistic understanding of training-induced AF based on studies in rodents. And I have to say, here's where my theory starts to fall apart a bit, as previous work by Stanley Nattel's group has shown that parasympathetic block rescues training-induced AF susceptibility in rats. And this was attributed to a downregulation of the RGS or GS protein signaling, which increases cholinergic sensitivity of the trained atria to carbachol, for example. However, these findings were not reproduced by follow-up studies by a Chinese group in rabbits. Instead, in this study, there was an upregulation of the GERK channels that carry IKACH and a corresponding increase in IKACH, and this was given as a candidate mechanism. And this, once again, was not reproduced by the work of Peter Bax, who instead found some remodeling of the L-type calcium channel, and also predominantly attributed training-induced AF to increased inflammation, TNF-alpha, and structural remodeling within the atria. So a complicated picture, nevertheless reiterating the role of electrical and structural remodeling within the atria in training-induced AF. And to this complex picture, we add another potential player. So this is the brainchild of my colleague, Gwyl Morris, who's a BHF fellow and also a consultant cardiologist. And Gwyl reminds us that the primary triggers for paroxysmal AF in clinics are focal sources originating from the pulmonary vein sleeve myocytes, combined with a propensity to anisotropic conduction in the pulmonary vein antra. And therefore, electrical isolation of the pulmonary veins from the working myocardium of the left atrium is effective in suppressing paroxysmal AF. Now, these findings have spawned many studies on the basis of ectopy in the pulmonary veins, and basically a unique electrophysiological profile of the pulmonary veins, where you have a reduction in IKS, an increase in IF, that contributes to triggered and reentrant mechanisms. Now, these can include EADs in response to rapid atrial rates, short action potential durations with a slow upstroke. Interestingly, there's also controversial, albeit histological evidence of pacemaker-like cells within the pulmonary vein. And also pulmonary vein fiber orientation has been previously given as further contributing to reentry. Now, with all this in mind, we swim trained some animals, and my colleague Sunil Lagantha, first using extracellular potential recordings, showed that in pulmonary vein sleeve myocytes from trained animals, the impulse originates in the pulmonary vein and moves to the left atrium. And using sharp microelectrode recordings, he also showed a spontaneous burst of activity in trained pulmonary veins with early after depolarizations. And also from triggered action potentials, he observed spontaneous depolarization and sharp bursts of activity. Unsurprisingly, this was associated with electrical remodeling within the pulmonary vein. Now, this is a study in its infancy, and I encourage you then to watch this space. So you'll be pleased to know that we've come to the end of this Zoominar. And what have we learned in the last 5 years or so? Well, public participation in endurance events is on the rise. And more than ever, you have people participating in ultra-endurance events. And with this comes an increased risk of cardiac arrhythmias. And against this backdrop, we were the first to show that with training comes an intrinsic electrical remodeling of the pacemaker of the heart, the sinus node, and specific electrical remodeling of the key pacemaker current, IF. In the long term, this remodeling is not restricted to the sinus node, occurs elsewhere in the heart, notably the AB node, and this is sufficient stimulus for heart block. We're starting to understand the mechanisms by which these ion channels are remodeled, with specific emphasis on microRNA transcription factor interactions. And targeting these, we believe, could be the first step towards small molecule therapies for rhythm disturbances in athletes. the role of a high vagal tone in training-induced AF, I think the jury's out. But nevertheless, there seems to be definitely a case for electrical and structural remodeling. And in this backdrop, we're exploring a role for pulmonary vein ectopy induced by training. So in closing, I'd like to say that what we observe, these type of microRNA transcription factor interactions as candidate mechanisms of transcriptional remodeling, are by no means restricted to endurance exercise, but occur in other conditions. For example, from recent work that we're currently revising for heart rhythm, this can also explain nocturnal brady-arrhythmias, another condition that's entirely attributed to high vagal tone. And also in heart failure, we just have a paper out in press showing that targeting microRNAs rescues sinus node function by rescuing a reduction in funny current density. So from all these approaches, the general theme of our work going forward is towards epigenetic therapies for rhythm disturbances. I'd like to finish on a very important slide. So this is obviously a team effort, and it is my incredible privilege to work alongside some super talented people. So primary thanks go to my mentor, Professor Mark Boyett, also the inspiration for much of this work. Also thanks to my senior colleagues in Manchester, at home and abroad, without whom none of this would be possible. And of course our funders, project grants from the BHF and personal awards from the BHF, the ISHR and the ESC. And thank you very much indeed for listening. Happy to take any questions.
Switch my microphone on. Alicia, brilliant. That was wonderful. Thank you very much. I have 3 pages of questions here.
Oh dear.
Almost entirely from me, but we've also got some questions on the Q&A. So without wishing to be too selfish, we will move to the Q&A in a second. But before we do that, Rudo Fischmeister reminded me something I had forgotten, which was your association with the ISHR also includes your ISHR Survey Fellow for a year, I believe.
I read that in my bio, but you didn't read it out.
No, I apologise. So thanks, Rudo, for reminding us of that. Let's cut to the chase and go to some questions. Alicia, I don't know whether you can see the questions, but I will read them out for the benefit of the audience. So we've got Emma Robinson, who says, thanks a lot, Alicia. Are you considering or worried about organ or cells type targeting of microRNA therapy, such as nanoparticle mediating targeting? So,
well, nanoparticles sounds really sci-fi. So at the moment, what we're trying to do is have AAV-mediated specific targeting of the cardiac conduction system using HCN4, for example, or the HCN4 promoter. And this is the work of one of our very talented PhD students, who I hope is listening, Luke Stewart. But this is something we're developing as time goes on. So yeah, I think because microRNAs do target a number of things, this is going to be crucial in this approach, that we need to have node-specific targeting or targeting specific cell types.
Sorry, by the way, he's not listening, so I think you need to tell him.
He's in trouble.
Well, I may be wrong.
Sorry, I'm listening, but I was trying to read the questions at the same time.
No, not you, Mike.
Our PhD students not listening.
Okay, so Ian Dixon sort of
asked. He's listening.
He's listening. I typed in the wrong name then. I apologize.
Hi, Luke.
Ian Dixon asked a question that I'm sort of interested in as well. He says, very nice work, Alicia. I missed the details about the etiology of the disease. Are swimmers more prone to electrical remodeling versus other forms of training? So, interesting question.
I think very little is known about what form of exercise portends to arrhythmias. I think with AF, cross-country skiers and cyclists, marathon runners appear to be especially prone. I don't think that I have yet to see anything directly in swimmers. Why do we use swimmers? It's just because, as you know, Mike, it's cheap and effective. You don't require a great deal of kit. You have a bucket, you have some water, you have some ice, and off you go.
Hopefully the Home Office aren't listening. But.
Yeah, I know. My project license is being revoked as we speak. No, I think it's reliable, it's reproducible, it produces several of the training adaptations that we expect, the hypertrophy and skeletal muscle oxidative capacity. It's just, in our experience, a very reproducible model.
Let me ask you a question, butt in and ask you a question related to that, really, which is, as you probably, or you may or may not know, Mike Tipton and I put forward an idea that arrhythmias in elite athletes, in particular triathletes, when they're entering the swim phase, may be triggered by autonomic overload, if you like. We call it autonomic conflict. And with the idea that sort of extreme sympathetic and parasympathetic activity simultaneously when you go swimming might be a trigger for arrhythmia. Now, you said, look, okay, vagal tone isn't responsible for the bradycardia, but what about the idea that when you have a remodeled node like you're describing in an athlete, do you think that node becomes more vulnerable to autonomic triggers that, for example, going swimming, getting your face wet, getting a parasympathetically driven bradycardia on top of a exercise-induced tachycardia? Do you think there's any evidence that there may be a susceptibility because you've remodeled your node?
I've heard your talk on this, and I think it's very compelling, and diving bradycardia could explain some of these things, but I think we're clutching at straws in terms of concrete evidence, because it would imply also that the autonomic nervous system was remodeled in some way, add that to an already remodeled node. There's a lot of ifs in there for me, but yeah, it sounds plausible, I would say. Yes, but it's not something we've explored yet.
Okay.
But Alicia, so do you mind, Mike, if I just butt in now?
Absolutely.
So when the mice swim, particularly sort of at the latter stages of your protocol, are you seeing more deaths following immersion?
I can proudly say that we have never maybe we've swim trained 300 animals or something over the years, and we have never had a single death in the pool.
Excellent. Hopefully the Home Office are listening then.
Home Office makes us happy.
Yes, okay. This is why it's such a great model, and they just immediately take to it, and the adaptation occurs very quickly, and they become leaner and fitter. And I always say to the Home Office inspector, I'm sure they enjoy it, but I have no evidence for this either.
Richard Heads asks, Richard says, great talk, thanks. Igor suggested that fibrosis protects the automaticity of node cells rather than promotes reentrant arrhythmias, but maybe inflammatory fibrosis is somehow different. Also, TNF depresses cardiomyocyte contractility via P38 MAP kinase, maybe has a similar effect on conduction. So a number of questions. Yeah,
I think this is kind of Peter Bax's area. Fibrosis is something we're only starting to think about, and that's in the context of aging. So in our rodent models, and also in horses, we don't really see any evidence of dysregulated fibrosis genes or things like that. So, but Peter Bax, who by the way has a much more intense model than us, he sees this inflammatory infiltrate. And I think, yeah, that's probably the stressor and the trigger. So from discussions I've been having with Mark Boyd and others over the last couple of weeks, we know now that, or we theorize that inflammation it could be a key driver of the remodeling by, we think, interactions with, among other things, with toll-like receptors. And yeah, there's some mechanistic things to be looked at there. But also the thing to note is that athletes also seem to be this hyper-inflammatory condition. C-reactive protein is elevated post-race, and troponins are all over the place. So yeah, I think it's going to be a hot topic. Yeah, but I think Peter Baxter's explored this in 2 papers now, showing that suppression of TNF-alpha completely reverses training-induced AF. So it's very powerful evidence.
Sanjay Kasha says, very beautiful data. My question is, how well is your in silico model informed by your extensive data? Has it shown what is the dominant factor, IF or L-type calcium current?
I know Sanjay, so I'm cross he asked this question. So, no, Sanjay, we don't know which is the dominant factor yet. we're trying to do, well, this was prompted by one of the reviewers. If you block them individually, in vitro, for example, in the isolated AV node, which one is more predominant, but we don't know yet. No.
Okay. Dan Johnson, thanks for a great presentation. More a technical question. I was wondering whether the PV cells were isolated or did you do this in slices?
So what we did, and this is the expertise of my colleague Sunil Logantha, who did his PhD on pulmonary veins in Strathclyde. And so it's a left atrial preparation with a common pulmonary vein intact. And so he's done sharp microelectrode recordings on this preparation. So they weren't isolated, no. I don't know how we'd isolate pulmonary vein cells in a mouse, but I'm sure we'll get there eventually.
Can't be very many. Mark Anderson, very interesting, thank you. Because this process of remodeling appears conserved across species, I wonder if you can speculate on how exercise downregulation of multiple sino-atrial node and ion channels may somehow be protective or beneficial. So how is it beneficial?
It's a bit, this is a loaded one, isn't it? So I think initially, so both sinus bradycardia and probably, well, let me just talk about sinus bradycardia because it's simpler, is that you have a hypertrophied heart and so stroke volume is increased. So it simply doesn't need to beat as fast. So maybe this down regulation accompanies that, it's energetically more efficient, perhaps. So that's my speculation on the protective mechanisms. But we know from other things that are initially adaptive, there's a point of no return and then they become maladaptive. So that would be where I'm going with this.
I think if you can answer why a slow heart rate is good for you, a Servier will give you lots more money as well. So
I think I'll ponder on that one. Right?
Yeah, definitely. This is a bit. Mark Boyert's asking you a question. Hi, Mark.
You just phoned me.
He says, I know I've been involved in the work, but I can still ask a question, exclamation mark.
No.
MicroRNAs may be immediately responsible for the changes, but what is causing the changes in the microRNAs? Okay.
I think we have started thinking about this extensively over the past couple of years, because we always get asked, what is the ultimate driver of the remodeling? Yeah. And there's a couple of avenues that we're exploring. So the short answer, Mark, is ask me in a couple of years. And the long answer is that, inflammation seems to be probably a big one. But the other one is, controversially now to what I've just said for the past half an hour, is the autonomic nervous system, but not in the way that you'd expect. So we have this theory, supported by some pilot evidence, that it is heightened sympathetic drive that really causes the remodeling. Now, this has been described in other conditions like heart failure, where you have sympathetic activation and CMP responsive elements that affect transcription. But it's a little bit too early for that to come to that conclusion yet. But that's one angle. And the other one is the vagus nerve, but not as we initially, not through acute changes in ionic conductance. So we have an ongoing collaboration with Matteo Mangoni in Montpellier, and he's finding a role for IKACH in this, but almost as a signaling hub and not really. So I think these ion channels have a double life almost, and not only do they do what they're supposed to do, but they also act in signaling complexes, which ultimately impact gene transcription. But Mark knows all this, so he's cheating.
What happens, sort of related to that, what happens if you vaguely denervate an animal and then exercise train it?
So this has been done, I think, by the lab of Billman, and I think he finds that they don't develop a training-induced bradycardia. But I think the caveat to that is human athletes with cardiac transplants still have a training intrinsic bradycardia. So I think the jury's out. And I think I have to say that when it comes to atrial electrophysiology, the dog seems to be an outlier in a lot of things. Some things just happen in dogs.
Which is a bit of a shame, because lots of people use it for AF studies, but never mind.
Yes, but let's not go there.
Okay. Ian Dixon says thanks. Rosanna Bassani says, hi, Rosanna. Thank you, Alicia. Very nice results. I was wondering if you have any idea on what would lead to the microRNA regulation of calcium channels and HCN, e.g. high heart rate. So it's a bit related to...
Yeah, so I think it's the similar mechanism. I think my pet theories are inflammation or the autonomic nervous system in a non-fundamental way.
Mike, can I ask a quick question here?
Yeah.
Alicia, have you actually by any chance looked at what's happening to macrophages?
Not yet. I know you're referring to that paper in Cell, where there's electrical communication between myocytes and macrophages, but it's not something we've looked at really. I mean, the inflammasome is like Mars, really. We haven't gone there yet, and I think, but from anecdotal evidence, because some of my colleagues were working on the ultrastructure of the AV node using serial block phase scanning EM. And we really don't see that many macrophages in there, is what they tell me. So I'm not sure about that one. I think there's a lot to do.
That's interesting. Okay.
So we touched earlier on different types of exercise having different types of effects, and we weren't sure there was anything there. But Richard Hess comes up with a new crazy theory. Marathon runners, cyclists and skiers all use their legs and the swimmers use their arms. I guess if you're swimming, you might have different venous return or different, I don't know really, but...
Are you telling me swimmers don't use their legs? I've been swimming all wrong.
I'm not sure what his point is, but it may be something to do with venous return. Douglas Jones, very interesting information. Although you have focused on IKACH, have you any information on the M3 receptors? Interesting. And sympathetic parasympathetic balance changes with training and arrhythmias.
So we tend not to, well, the M3 receptor, I just first heard of it not that long ago when we did some in that RNA-seq data set. So it's not really something we considered at all. With parasympathetic, sympathetic balance changes, well, the only thing we've done is look at sequential blocks. So first sympathetic and then parasympathetic block and vice versa. But I must admit, we've spent the last 10 years saying that it's not the autonomic nervous system and we can't consider it. So we haven't looked at it in great detail yet, no. But I'm sure, I think I'd like to say that I don't believe that there's no role for the autonomic nervous system. That's not the point. It's just that we haven't been able to, as far as I know, no one's been able to really definitively show its involvement. It's all based on surrogate measures and like heart rate variability and the rest, and the rate response to pharmacological block, which again is not perfect. You know, these are systemic blockers. But I think I was just saying to someone before this talk that the burden of proof is on the Vagal people to show that there is a role for this in training, so not me.
I think we've had 100 years of thinking that it's probably Vagal. And I think you showing us that there's ion channel remodeling and the intrinsic rate of the node is changed really makes at least them, as you say, put the burden of proof back onto them to say, look, it's...
Yeah, balls in your court, yeah.
Excellent. You've also, I know, historically have done a lot of work on ion channel remodeling in circadian rhythms. So Beverly Rothermel asks a very interesting question. There is emerging evidence that long-term metabolic outcomes in responses to high-intensity exercise can be profoundly impacted by the time of day exercise occurs. So here we go, bring your two interests together. Could this account for some of the variability from lab-to-lab study outcomes? I'm curious at what time of day, the animal's activity period, are you carrying out your studies? So do these things interact?
Yeah, so excellent question. Thank you, Beverly. And also a difficult one because you're about to show me up now. So yeah, we had this long-standing interest in the circadian rhythm, and we're hoping that our paper, which is being revised for heart rhythm, where we show that there's a time of day electrical remodeling within the sinus node. So yeah, I do think that impacts exercise physiology. What time do we swim train our animals? Or I'm afraid that we're bound by institutional regulations. They won't allow us to come in at night and switch the lights off and put some mice, get them to swim. So unfortunately, we've always had to do this in a normal working day without time shifting animals. And I think, there is I think it could be refined, we could time shift them, and that is something we're exploring because we have evidence that ion channels do show a time of day based remodeling. But I'm not sure.
You're essentially getting your animals up in the middle of the night to make them
Yeah, that's right. But I think the reverse argument to that is, I'm sure anyone who's worked with rodents, you walk into a facility in the day and it's not like they're all snoozing. They sleep in like 5-minute bursts, and we have considered the activity cycle of a mouse in great detail recently in response to those comments and so on. And I don't think that they have 12 hours of an active phase and another 12 hours where they're quiescent. The activity is really mixed.
Yeah, I mean, if you woke me up at 2 o'clock in the morning and asked me to swim in a bucket, I think I'd have an arrhythmia as well, probably.
I know that they have arrhythmias. Yeah, but I take your point. It would be nice in the ideal world to have a system where we could only train them in their active phase that would be kinder to the animal, perhaps. But I contend that these animals have been in this dysfunctional light-dark cycle. They're bred in captivity. There's loads more activity in the day. I think the physiological outcome that we have reported still stands despite this problem.
But to be fair, you're seeing similar remodeling in horses as well, right?
Yes, that's right. Oh, thank you, Davo. That's a good point. Yes, that.
I'm trying to help.
As far as we know. Yeah. Anonymous attendee says, nice talk, Alicia. What happens when the mice stop exercising? Is everything back to normal like AV Brock?
Yes, the short answer is yes. Detraining reverses this type of remodeling. But I think in human athletes, there is evidence that in the long term, with sustained exercise, there comes a point where you do not see a complete reversal. There's still changes that persist. So yeah, detraining is really interesting because my clinical colleagues say that compliance in detraining studies is notoriously terrible. And these people don't want to stop training. So yeah, it's an important avenue.
I have the opposite problem.
Yeah, me too.
And finally, Adina Hazan says, thanks for the talk. What model did you use for the in silico studies?
So this is a model developed by Hengui Zhang. It's previously detailed by him, and it's a biophysically detailed one-dimensional model. And I can't quote his paper just now, but I'm happy to provide these details.
Okay. Could I perhaps finish? I mean, we've got to the end of the question, so well done. It's perfectly timed in terms of timing as well. So thank you, Alicia. Maybe I could finish by bringing us back to where we started, which was an introduction talking about Igor Efimov's talk on Friday. So when you train athletically, is there any evidence that the primary pacemaker site moves either within the node or indeed to perhaps an inferior sinus node? Or is there any training?
We haven't done any optical mapping on these preparations yet. We have them planned for other things, but I think a lot of people who do this type of work know that in response to acetylcholine, for example, you have a shift towards more inferior regions. And we've yet to see that in trained animals or anything like that. But I think, yeah, it's an interesting prospect. But it kind of reminds me of the work of my colleague, Helena Dobrinsky, in goats. And Helena described this paranodal area where you have these islands of pacemaking cells near the inferior vena cava. So I wonder that's what Professor Efimov was referring to.
I mean, Igor still has got to come up with an explanation as to why we have two sinus nodes, and indeed why in heart failure either one or other tends to predominate. So it'd be very interesting if there was a training-induced bias towards one node versus the other.
Yeah, that would be really interesting, wouldn't it? Yeah, I think something.
So one or other of you is going to go away and put mice in a bucket.
Yeah, it's not me. We're still under full lockdown, unfortunately.
Excellent. So thank you, Alicia. We've come to the end of the questions. I've learned a lot. It's been really a superb webinar. Thank you very much. I absolutely love what you're doing, so carry on doing it. It's really fascinating physiology. And as a physiologist, of course, I would say that. So thank you, Alicia. Davor, is there anything?
Thank you for having me.
finish off with?
No, I mean, I'd just like to thank you again. Same as Mike. Really, really impressive work. I've not seen a lot of this, and thank you for showing it to us before the publication, which I'm sure will be inevitable.
I hope so.
So thank you, everybody out there, for tuning in again. Hopefully see you tomorrow. And thank you, Alicia, for a wonderful webinar.
Thank you very much for having me.
Thank you.
Bye, everyone.
Bye, everybody.